In today's video, I want to talk about vitamin D resistance, specifically acquired vitamin D resistance. And this is an issue. I wouldn't quite call it a diagnosis because I don't think most of the world is aware of this. But there has been research on this since the early 1900s and people talking about it that long. And one reason for that is that there is genetic vitamin D resistance, which, there are many genes that control vitamin D physiology. And so if you've got a SNP or a mutation in one or more of those genes, that would be a genetic or congenital version of vitamin D resistance. But most people are not going to have the genetic version. Most people are going to have an acquired version, and an acquired version is not genetic. This is due to a combination of possible single nucleotide polymorphisms or SNPs or gene variants on one side, and then lifestyle factors on the other, such as, sun exposure and diet and aging and infections and stress, etc. And we'll talk about that more as we go. So first, I want to give you a little bit of a physiology lesson on vitamin D and how we make it, and then we can talk about vitamin D resistance and where it's coming from and why it matters. And just to keep you intrigued here, vitamin D resistance is believed by some authors, particularly the ones of the study I'll show you in a little bit, as a big reason for autoimmune disease. And so if we can identify vitamin D resistance in patients with autoimmunity or patients looking to avoid autoimmunity and correct it, then we may prevent autoimmune disease or help reverse it. And one key autoimmune disease where this is extra important is multiple sclerosis. And then the authors closed the paper suggesting that vitamin D therapy could be huge in cancer as well, because it's plausible that vitamin D resistance is present in cancer. So first, let's learn or relearn vitamin D physiology. The vitamin D receptor is going to be key in this story, and we'll talk about that as we go. And I'll link to a video here that we did in the recent past discussing vitamin D receptors, and the question from a participant in the call that asked, I take vitamin D, why, and the person next to me takes vitamin D, why is her vitamin D level higher than mine? And the answer to that was partially maybe differences in vitamin D receptors between the two people. So let's first start with the sun, because we all know that vitamin D comes from the sun, right? And specifically, vitamin D comes from the UVB rays of the sun, or ultraviolet type B rays of the sun. And this is one reason why we don't want to use sunscreen that's blocking ultraviolet light or blocking all of it for us, because the UVB rays and the UVA rays are very important for our health. So before I get too far down the rabbit hole here, let me just break off and say the UVA rays are important, not so much for vitamin D, but for nitric oxide production, which is one of the body's main vasodilators. Okay, so lowering blood pressure and heart health, etc. So we don't want to block the UVA rays for that reason. UVB drives production of vitamin D. And so how does that happen? Well, the first step is it has to hit our skin. Okay, so say we have someone's arm here, right, with a hand at the end, and we'll just draw it not to scale. All right, but the vitamin D hits our arm, okay, and when vitamin D doesn't hit our arm, the UVB rays hit our arm here, bing, 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 and when it hits the skin, in the skin, there's a reservoir of what's called 7-dehydrocholesterol. And we've made a video on this in the past, but this is a reminder for you. And when the UVB rays combined with heat to hit that 70 hydrocholesterol, and the heat is body heat. That 70 hydrocholesterol turns into what's called pre-vitamin D3. And then the pre-vitamin D3 is converted to vitamin D3, the 25 hydroxy form, and that binds a vitamin D binding protein, and that travels to our tissues. Okay, so we'll use a different color for our body tissues. Let's use purple. So we have body tissues, okay? And when the vitamin D meets our tissues, which could be, say, the kidney, as an example, it could be the heart, it could be our immune cells, okay? When the 25 hydroxy vitamin D makes its way into the tissues will then convert it to 125 dihydroxy vitamin D, which is a lot of nerdy terms, but just know that the vitamin D that your doctor usually tests is 25. The 125 is the most active form in the body, and this is the one that has the pleiotropic effects in our body, okay, ranging from bone health to immune function to cardiovascular health to kidney health to basically almost all tissues absorb vitamin D. Okay. And the way that it has its effects, the 125 has its effects, is it goes inside the cell and binds the vitamin D receptor in the nucleus of the cell. And by binding the vitamin D receptor, the vitamin D receptor controls over 1,200 genes. And those genes code for all the functions of the various tissues. Okay. And so it gets the pleiotropic effects, or that's just nerdy for all the many effects that vitamin D can have for us. So the vitamin D receptor is the final common pathway in terms of going from the sun to the effects of vitamin D for health benefits in humans. And so it's very important to know this, because if there's a stick in the spokes anywhere on this pathway, right? If we don't get enough sun, that could lower our D. Okay. And when you don't get enough sun, remember the 70 hydrocholesterol, instead of going to become pre-vitamin D, what happens is it becomes total cholesterol. So not enough sun exposure can raise your cholesterol. And we covered that in previous videos. So you may have high cholesterol because you live at a latitude that gets poor sun exposure, not because you're eating too many eggs, as an example. Okay, so poor sun exposure, poor vitamin D. And what have we seen in multiple sclerosis? Multiple sclerosis is more prevalent in higher latitudes or places with less sun exposure. This may be one of the mechanisms. Low sun exposure, less vitamin D production, okay? Less vitamin D conversion to 125, less 125 binding to vitamin D receptor, less expression of 1,200 genes, including the immune genes, all right? Or osteoporosis, right? Not enough vitamin D, maybe you don't get enough bone growth, osteoporosis. Kidney issues, cardiovascular issues, all down the line. And so it's very important to know how to make vitamin D. Yes, we can get some from diet, but the sun is the best source. And then we have to have efficiency down this pathway. Now, here's the issue. Vitamin D resistance, how do we know if we have it? Okay, so you might say, well, I have low vitamin D. Low vitamin D, specifically the 25 hydroxy form, which is the most commonly tested one. And if you have that, you don't know if you have vitamin D resistance yet. You know you have low vitamin D, and low vitamin D can lead to all these things, that all the X's that we just drew up here. So it's not good to have low vitamin D, for sure. But that doesn't necessarily mean you have low vitamin D resistance. You just might not have enough D for your physiology to work, and that would be easy. The answer would be get your vitamin D up to optimal. Okay. But what if you have optimal vitamin D. So what if you have optimal vitamin D3 and you still have these health problems? Well, to check if you have vitamin D resistance, we then need to test parathyroid hormone. What? Why? Well, because vitamin D and parathyroid hormone are a feedback loop. And in a healthy person, if you have optimal vitamin D, that should be suppressing your parathyroid hormone so that your calcium metabolism is correct. Okay. And so if you have optimal vitamin D and you have optimal parathyroid hormone, which you want your number to be in the lower 1/3 of the normal range, if you have a parathyroid hormone in the lower 1/3 of normal range and optimal 25 hydroxy D3, you're good. You don't have vitamin D resistance. But if you have optimal vitamin D3 and you have high parathyroid hormone or higher than the lower 1/3 of normal, then you know that this negative feedback loop isn't occurring and you have some form of vitamin D resistance. And that vitamin D resistance can lead to health issues. And this is how the question that the person asked before that I referred to, I'm taking vitamin D and I have, quote, normal levels, but I'm still having issues. Why? Well, this would be an answer for that person. If you're taking vitamin D and it's not, your level's not going up, or your level's going up, but you're not improving in your symptoms and disease state, well, then it's time to test the parathyroid hormone and understand if that feedback loop is broken. If your D is optimal and your parathyroid's still elevated, then you have vitamin D resistance, and we need to figure that out and take care of that. Okay. And again, well, what is driving the vitamin D resistance? Any number of these things. And so addressing these things would help improve vitamin D receptor function, improve vitamin D levels and vitamin D inhibition of parathyroid hormone, removing the vitamin D resistance. So I know this might be a lot right now, and it's a beautiful picture in my opinion, but jumbled. So let's jump over to the research and look at the images they drew and see if we can glean more information here. All right, so here we are on with the journal Frontiers in Immunology from 2021, and the paper is titled Vitamin D Resistance as a Possible Cause of Autoimmune Disease. And if we dive into this, okay, they talk about vitamin D3 is a steroid and prohormone, which is metabolized in various tissues to the most biologically active form, vitamin 125 dihydroxy vitamin D3. Okay. And it's the 125 form that has the pleiotropic effects on the immune system, the heart, the bone, and all of that. Okay. So these authors are saying, okay, if vitamin D resistance is real, can high dose vitamin D help autoimmune disease? That's the main goal of research for this paper. The necessity of high doses for vitamin D3 for treatment success can be explained by the concept of an acquired form of vitamin D resistance. Its cause is based on the one hand on polymorphisms within genes or variants within genes affecting the vitamin D system, causing susceptibility towards developing low vitamin D responsiveness in autoimmune disease. On the other hand, it's based on a blockade of vitamin D receptor signaling, for example, through chronic infection. Okay. So if we go down here, they walk through all kinds of good minutia if you like that, but let's dive in here. We are interested in a non-hereditary but acquired form of vitamin D resistance. Okay, so as we said, there is a genetic form, but that's obvious. You've got a genetic defect causing your D resistance. We are interested in the non-hereditary but acquired or lifestyle environmental form that you weren't born with, you didn't have your whole life, but then you developed. And so we can win against that because if we figure out, well, what were the factors that drove your acquirement or your development of the vitamin D resistance, we can remove those, we can help you. A hallmark of acquired vitamin D resistance, if it exists, would be an elevated parathyroid hormone concentration despite 25 hydroxy D3 levels being ideal. A physiological 25D3 level should thereby be able to suppress parathyroid hormone into the lower third of the reference range. In other words, if your vitamin D levels are high or optimal, parathyroid should be low and vice versa. In patients with autoimmune disease, this negative feedback loop is disturbed. Approximately 25% of the population is not responding adequately to conventional vitamin D3 doses. They may require individually varying but higher doses. So again, back to that question from the participant, I'm taking vitamin D. Why isn't it helping me? She might be one of the 25% of the population not responding to what is believed to be adequate dosing, right? The dosing recommendations from the FDA and CDC are woefully inadequate for anybody. But even the optimal dosing that I recommend very regularly could be inadequate for up to a quarter of the population. So again, rather than making blanket recommendations, it'd be better to test the individual in front of me to figure out what is the best dose for them and their puzzle. As I said earlier, vitamin D resistance first was proposed in 1937. So this is not new. It's new to us, but it's been talked about for a long time, almost 100 years now. And so, we want to dive further into it. Okay, so vitamin D resistance diagnosis. How can we do this? Parathyroid hormone provides a valuable and easy to measure biomarker for the clinician. As mentioned above, 125D3 and parathyroid hormone stand in direct relationship with each other. A high parathyroid hormone concentration is associated with higher all-cause mortality rate. Okay, so if you have high parathyroid hormone in epidemiologic studies, they found people with the higher the parathyroid hormone, the higher the risk of death from all causes. Why? Well, that's suggesting that there's a vitamin D resistance. And if vitamin D resistance is present, you're going to be at higher risk of death from all causes because vitamin D is so important in almost every disease. So what they say is we want to have an optimal 25D3, which they say is greater than 40. I'd say you want it greater than 50. So you want that optimal level, and then you want the parathyroid hormone in the middle of the lower third of its laboratory specific range. So they say in such a case, high parathyroid hormone levels are indicative of vitamin D resistance, assuming that your dietary calcium and phosphate intake are adequate and that we've ruled out hyperparathyroidism. Okay, so for example, the reference ranges vary depending on your lab. But in their example, they say if the lab's range for parathyroid hormone is 15 to 65, the middle of the lower third of that range would be 23. Okay, so you divide the normal range into three, and you want to be in the middle of the lowest range, or the first third. There are multiple genes and enzymes that control production of the 125 and degradation of the 125D3. So that's what that's talking about. But they say that the best markers to figure out do you have it is your 25 hydroxy level next to your parathyroid hormone level. How do we develop vitamin D resistance? Well, you have inefficient vitamin D receptors. What can do that? Many things. Okay, so if we look at a few here, aging is one. We're all aging, right? And so there is a physiologic decline to your vitamin D receptor function that is expected because it comes with aging, which is not necessarily great, but we'd all rather age than be dead, right? So as we age, there is a physiologic decline, which is expected. But things that can pile on to that physiologic decline and accelerate it, and things that are actionable, since we're getting better at taking, anti-aging strategies, but we can still win further by preventing chronic infection, ridding ourselves of unnecessary stress, ridding of ourselves of unnecessary toxic exposures, right? And so if we can remove those things, then we can promote optimal vitamin D production, optimal vitamin D receptor production, and optimal immunity, which is then going to prevent immune imbalance, which can drive autoimmune disease, as well as cancer. So we need to have optimal sun exposure and optimal D physiology and remove as many negative things as we can. The vitamin D receptor is probably the most vulnerable part of the vitamin D system and constitutes the most likely, or at least the most potent manifestation of acquired vitamin D resistance. So again, bang for our clinical action. Where can we win the most? At the vitamin D receptor. And how do we win there? By eliminating the things that are a stick in the spokes to the function of the vitamin D receptor. So living a lifestyle that removes these things or helps us rid ourselves of them as efficiently as possible. Here's a comment. Vitamin D receptor modulates 1,200 genes just in the human monocyte. So that's one immune cell. Okay. So how important is the vitamin D receptor? Very. Okay. Especially, for everything, but right in this context for the immune system. Here they're talking about different gene variants related to the vitamin D receptor and risk of autoimmune diseases. And here's where they're saying that there's been a couple discovered, specific to MS. Vitamin D receptor is regulated by many factors. Okay. Check this out. The first evidence for a vitamin D receptor was found in 550 million-year-old boneless vertebrates. So the vitamin D receptor evolutionarily is very, very important and is conserved across many, many life forms. Okay, so this was here way before humans. Okay, so the vitamin D receptor is key to our physiology. Well, what's one thing that really is a stick in the spokes? Glucocorticoids or cortisol. Okay, psychological stress, the fight or flight response, stress reaction. All right. So when we are stressed, we are doing all kinds of things that we've talked about in the past, right? The effect of the tiger. But here, specific to vitamin D and vitamin D receptor, if the vitamin D receptor is chronically inhibited due to long-term chronic stress or long-term cortisone treatment, like prednisone, other corticosteroids, this would explain the occurrence of pathological consequences such as osteoporosis. So chronic cortisol use, corticosteroid use promotes osteoporosis. Here's one mechanism why. Steroid use inhibits vitamin D receptor. Vitamin D is needed to build bone and have healthy bones. So why I don't, I'm doing weightlifting, I exercise, I'm loading my bones. Why am I still losing bones? Well, if you're exercising, but you're full of psychological stress, or your exercise is too much or overtraining so that it's sending you into fight or flight response all the time physiologically, that could be behind the bone loss. Chronically elevated glucocorticoid levels have been shown to compromise 125 and promote development of osteoporosis. What else? We talked about chronic infections. Well, lipopolysaccharides, which are the gram-negative endotoxins, or the endotoxins produced by gram-negative bacteria, they inhibit vitamin D receptor function. So if you've got gut dysbiosis, an unhealthy gut, and you've got all kinds of gram-negative bacteria floating around in your gut, like H. pylori or E. coli or Klebsiella, Citrobacter, Enterobacter, Pseudomonas, Morganella, there's tons of them. They're producing LPS. Well, LPS inhibits your vitamin D receptor function, which makes it harder for your immune system to clear pathogens. So these pathogens have co-evolved with us, and they're developing what are called pathogen evasion strategies, or ways to, hide from our immune system. And so they're smart. And so if they're succeeding in beating our immune system, we are less healthy. And one way they succeed in beating our immune system is downregulating the vitamin D receptor so that we're not producing antiviral and antibacterial compounds to combat them. All right. Who does that? Well, pathogens like Legionella, E. coli, Yersinia, Lyme. Look at Lyme created a 60-fold downregulation of the vitamin D receptor, 60 times lower than it should be. That's going to make it hard to beat Lyme and, promote chronic Lyme. Epstein-Barr virus downregulates the vitamin D receptor. Epstein-Barr virus has been implicated as a causal factor in MS. So imagine you're not getting enough sun and you've got Epstein-Barr virus, double whammy. Okay. Other infections like Campylobacter, flu viruses are associated. So pathogen-mediated temporary or chronic blocking of the vitamin D receptor can be explained from an evolutionary view in which pathogens have developed ways to attack this key target in order to downregulate the host's immune system. Like I just said, pathogen evasion strategies. They're smart. We're in a constant tug of war, and so we're constantly developing new weapons against each other, right? So here's a vitamin D deficiency is associated with a plethora of heart and metabolic diseases, including cancer, high blood pressure, chronic infection, autoimmunity. The proof of vitamin D receptor expression in the immune system, multiple cell types of the immune system is everywhere. There's multiple different effects of vitamin D on the immune system, such as bringing cells to infected tissue or damaged tissue, the cell's ability to kill infections, cells' ability to divide and proliferate, their production of inflammation and anti-inflammatory compounds, production of antibodies, antimicrobial peptides, and producing memory cells. So all kinds of functions in the immune system for vitamin D. So here's kind of the hierarchy of things to look at when that impact our risk for acquired vitamin D resistance. One is the gene setup. Do we have the genes, and are there variants in our genes where we dealt a hand that had more or less efficient genes? If we were, we can still function normally, okay? Because the genes are what the genes are, but the gene expression is controlled by above the line. So these two purple areas. So what's our exposure to environmental toxins like aluminum? Okay, it says up here, aluminum is one environmental toxin that can be a factor. There's many, okay? Steroids. You could look at steroids as an environmental toxin in terms of a vitamin D receptor context. Chronic infection we talked about, not enough sun, aging, okay? Other inflammatory factors like diet, physical inactivity, psychological stress like we talked about earlier. There's many areas that we can impact positively. So what do we do for vitamin D resistance? Okay. We need to take more D. Okay. And I'm not telling anyone what level they should take, but these authors were looking at people with vitamin D resistance. And if they had multiple sclerosis, they were giving those patients 1,000 IU per kilogram body weight per day. If they had rheumatoid arthritis, lupus, psoriatic arthritis, psoriasis, Crohn's, or ulcerative colitis, 300 to 500 IU per kilogram body weight per day. Scleroderma, Angst spondylitis, or Hashimoto's, 300. Others, 150. So these would all be considered by conventional medicine way too much, but the patients that need this are the ones failed by conventional medicine. So it's something to consider with your clinician. And again, provided close supervision by an experienced physician, the applied high doses of vitamin D are not causing hypercalcemia or kidney damage. But again, you want to work with a clinician that knows you and is doing testing so you can do it properly. So the authors conclude with vitamin D therapy and resistance. What did we learn? Okay, parathyroid hormone level in the blood remains the key information for vitamin D3 dose finding and determining do you have vitamin D resistance or not. The high dose vitamin D concept in autoimmune disease should be transferred to other areas for vitamin D therapy, such as cancer, diabetes, and heart disease, to name a few. Why? Because, again, of the pleiotropic or wide systemic effects of vitamin D that we get from the sun to the skin, okay? That's then bound to vitamin D binding proteins and carried to the different tissues of the body, like the immune system, the parathyroid gland, the liver, the kidneys, the intestines, and everywhere else. So let's open this up for questions.
I'll go, Dr. B. It's Melena.
Hi.
Hi. So can you test for the genetic vitamin D resistance,
Yes, that are involved. So for
VDR
example,
gene?
um, so it's not, you're not going to get a test that says VDR gene.
Okay.
Basically, you're looking at the genes that are involved in function of like the cytochrome P450 enzymes in the liver, for example. So these different enzymes are what catalyze um, these enzymes. So genes code for enzymes. Enzymes are proteins that do work, right? So you can
Mhm.
run genetic testing for the genes that produce these enzymes and see, do you have SNPs in those genes? And then if you do, that would suggest there might be a genetic susceptibility to reduced functionality of the vitamin D receptor. And then if you've got that plus, chronic infection, aging, toxins, stress, etc., that may be manifesting in a person's case. So the next question would be, well, how do you test that? I mean, probably the most efficient way would be to do like the 23andMe test, which will just run your whole genome, and then you could search out the specific genes for this. I'm not aware of a test that's clean, that's like, hey, these are the genes tied to the vitamin D receptor. Let's just run this. It takes some work, but it's able to be done.
Okay. Just another quick one.
Mhm.
Is there any difference between the vitamin D that we get from the sun versus vitamin D supplements um, in the way they're, or each of them is processed by the body?
Nope. Well, shouldn't be. Let me jump over here. So remember the vitamin D, change colors here. The vitamin D that's coming from the sun is from UVB light, and the UVB light's hitting the 7 dehydrocholesterol, pre-vitamin D, vitamin D 25 hydroxy. So what we're making from the UVB light is exactly what we're taking if you're taking vitamin D3 cholecalciferol in your supplements. This is
Mhm.
cholecalciferol. Okay, so if
Yeah.
you have a vitamin D supplement, you turn the bottle over and read in the parentheses, it'll say D3 cholecalciferol. That's what you want. If it says D2 ergocalciferol, which is what medical doctors often give, that's trash. You don't want that. Both what you produce from the sun or what you're taking via supplementation then has to go be converted to the 125, and that's happening in the tissues.
Bartemus.
Yep.
I, yeah,
Hi.
I came out as lab high for vitamin D, and so I was
Mhm.
told to reduce it. Um, so I found that it was actually in some of the supplements that I was taking, and so I stopped taking the actual D3 supplement. I forgot what happens if you have too much vitamin, if you have too much D3, too much D in your system. I forgot what that can
Yeah.
cause.
So the concern is over what's called hypercalcemia, which is nerdy for your calcium level will go too high. Um, but and that's a possibility, but it's much more rare uh, than implied when people scare you about it. I've had patients, so the normal range of vitamin D in most labs cut off at 100. I've had patients where, when we first met, they were low, and so we dosed them up, and when we retest, they were at 200, and their serum calcium was still normal. So they were at no risk of any kind of bad thing. Do I want their level at 200? No. But what we learned there is, holy cow, their body was accepting of the vitamin D and able to raise the level. So now we took them off until their level came back down towards our goal level for them. So if you have a high vitamin D, a medical doctor, if your vitamin D's medicine's crazy, right? Because here's what they're going to do. Medical doctors don't know nutrition in general. So what'll happen is you're going to go to your MD and they'll test your vitamin D level if you beg them, because they'll push against it first. And if your vitamin D level is 31, they'll say, Annette, your D is good, no worries. Meanwhile, the normal range is 30 to 100, right?
Uh-huh.
So that 31 is borderline lab low, and they're telling you you're normal.
Mhm.
And they're telling you take a osteoporosis drug. right? And it's like, well, what if we just got her D up to sufficient, which would be, 50 to 70, say, okay? Or they test you and your vitamin D is lab high at 108. Now they're saying, stop your vitamin D. You're going to have hypercalcemia and bad effects from that, right? Meanwhile, your serum calcium's normal. So they're taking you off something that's better and more powerful for your physiology than any medication they're going to give you because you're a couple points above the normal range. But when you're borderline low or a couple points low, if you're 25, they're like, it's not bad. Here,
Mm.
take 1,000 IU a day, but don't take more because that's the recommended daily allowance, right? So, um, each person we need to look at them in context, but in general, if your D is high but your serum calcium is normal, you're fine.
Okay.
But we still would like it, we would still like it not to be high, but it's not something like, okay, just stop taking it for a while and you retest your levels in 6 to 8 weeks and see where did it fall down to, and now how do we need to dose you to get you or maintain you in your goal dose. The research says the average adult needs 4 to 6,000 IUs a day. And that's, again, depends on where you are on the planet, how much sun exposure you're getting, how inflamed you are, blah, blah, blah. But, for the FDA to say 400 IU a day is enough, it's like that's why 70% of Americans are deficient, because that's not enough.
Mhm. Right. Okay, thank you.
Mhm.
I want to thank you for the immunology because I'm geeking out on it, of course. So,
Yes.
but also it helps me, like it just validates the fact that I know because I'm already susceptible because of the MS, and then you add the stress and all that. Like I tend to, it's like you kind of do things as you go through this journey, and I will take more vitamin D if I am stressed or if things are going on. And so I just this is good because I'm trying to, not impair my receptors. So this was great. Thank you.
Yeah, you're welcome. And again, the 4 to 6,000 is something, if we don't have a number on us, that's definitely safe for everyone to take. Okay. And that's something we should be doing daily, everybody, and unless we know our number, right? So if I had tested and I'm hot and I'm high and I'm wanting to bring it down to a go, say my numbers, say I want mine to be 65, say, but I test it and it's 108. Well, then I probably won't take 4 to 6,000 a day for a couple weeks, and then I'll retest it. And if I'm here on the retest, excuse me, now I'll take 4 to 6,000 a day and retest again at 4 to 6 weeks. And if I'm then 72, okay, well, I know that whatever I've been doing those last 5 to 6 weeks is a good maintenance dose for me to keep me in the range of what I'm trying to keep myself at, right? If I retested and I was taking 4 to 6,000, I retested and I was 48. Well, that 4 to 6,000 isn't enough to keep me where I want to be. So I need to bump it up. Okay, let me try 8,000 a day and then retest. So, um, again, working individually with a practitioner who knows you and you have a goal you're trying to hit helps you create the optimal daily dose or maintenance dose of D for yourself. And so once you have that, you do that. And if you move north or you're really stressed or much more inflamed because of whatever reason, you might need more for a short time. So again, these are numbers that are changing over time. Physiology is not static; it's always in motion. So this is why we should get updated labs every so often so we can see, okay, how am I doing now? Is what used to work for me still working for me, or how has what's happened in my life since my last test impacted my physiology, and do I need to change dosing, etc.